Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Please note that the information provided in this podcast should not be considered medical advice. We do encourage all listeners to consult their healthcare professionals for medical concerns. Thank you for listening, and we hope you find our discussion today enlightening. Hi, and welcome to SpondyCast. Today, we are going to dive into part 2 of Mother to Baby with a deep dive into pregnancy studies, patient participation, and the impact of spondyloarthritis research with Dr. Christina Chambers. Our guest today, she is a professor in the Department of Pediatrics, School of Medicine at UC San Diego. She is chief of the Division of Environmental Science and Health and co-director of the Center for Better Beginnings. She's also principal investigator of MotherToBaby pregnancy studies and the UC San Diego Human Milk Research Biorepository, two nationwide longitudinal cohort studies focused on the safety of medications, vaccines, substances, infectious agents, and other environmental exposures in pregnancy and lactation. Dr. Chambers co-directs the Healthy Brain and Child Development Study, also a nationwide research initiative focused on developmental trajectories of children in various environments from prenatal life through 10 years of age. In addition, she leads research and education initiatives in the U.S. and internationally on the prevention and treatment of children with fetal alcohol spectrum disorders, and co-directs the Center for Population Science and Community Engagement in the Clinical and Translational Research Institute at UC San Diego, which supports clinical research development in diverse populations. Dr. Chambers, you are a busy woman. Thank you for joining us today.
Thank you for having me.
So we're going to talk a little bit about Mother to Baby today, and I would love to hear more about the research side of it and your role. And I'd also love to hear how this became your area of expertise.
Well, thank you, and thanks for the invitation again to do this with this group. We love groups like yours. So I think hopefully you've heard in part one that one of the critical gaps in knowledge that we have in the U.S. and elsewhere throughout the world is good, reliable information on the safety of most medications that are used, whether they're prescription or over the counter. And in part, this has been due to the fact that pregnant women have typically been excluded from clinical trials due to concerns about the vulnerability of the pregnant woman and the developing baby. And so by the time a new drug comes to market, there frequently is little to no information about human pregnancy. And then we may spend 10 years, we may spend 20 years and still not have sufficient information to understand or be able to have a good feel for the risk or safety of a specific medication. And that's been the longstanding situation in the US and elsewhere throughout the world. So because our Mother to Baby counseling service, which has been around for almost 40 years now, deals with those kinds of questions every day, coming from clinicians, coming from patients, and the public, we thought some time ago, well, gee, we have an exceptional opportunity here to try to answer some of these questions, because we have people contacting us every day who've taken a medication, who say, I found out I'm pregnant, I'm taking this medication, what can you tell me about it? And we may say there just are no human data or not sufficient human data, but would you be willing to participate in a study with us so that we can actually hopefully answer that question sometime down the line? And so that's how this all got started, as a research arm of Mother to Baby, to try to develop better information in this vast void of data that's available for pregnant women and their providers. And that's how I got involved in it.
Wow. So am I hearing you correctly that a lot of times the data comes because you're hearing from a woman who's taken a medication and then you follow her through pregnancy and through
Yep.
the child.
Yep. So
Wow.
she may come to us through our counseling service, and it's frustrating to call and say, I found out I'm pregnant. I've taken this medication. This is what the label says. This is what I read on the internet about what happens in a rat or a rabbit. What can you tell me about me? And we say, there just isn't enough data. We can tell you something about, how we think the drug works, what other drugs in the same class might work, but we really don't have enough information to tell you, a whole lot. And we need to know in humans. And so that is one opportunity where she may say, this may not help me, but it may help the next person down the line, or my daughter, or my neighbor, or whatever, who's in the same boat, a few years from now, who had the same questions. And then we also, same situation, people get referred by their clinicians, who have the same questions, and they're willing to say, I'll take part in this so I can help somebody else down the line. And people also self-refer, who learn about us from our website or social media.
And is that really how you develop the studies?
That's exactly the core of how we developed the study. So we started back in the late 1990s, at what we call, terminology, but an open cohort study, meaning that we set up at one location at UC San Diego for the MotherToBaby organization, a single site pregnancy cohort study where we can enroll people anywhere they reside in the US or Canada who have an exposure to a medication or a vaccine or whatever it is that's of interest. But at the same time, we also can enroll people who don't have that exposure. So we have the unique capability of being able to enroll people who we can compare to mothers who had the exposure during pregnancy to a given medication, and mothers who have the same underlying disease like ankylosing spondylitis who didn't take that drug during pregnancy. And that's kind of the best comparison. And so
Okay.
that's the method that we use.
Wow. And was some of that in the late 90s? Was that born out of like a lot of what happened with more inclusive clinical trials going on? And,
You
or was
know,
it just,
Yeah, the movement towards more inclusive clinical trials is pretty new. That's actually the guidance from the FDA to say there are certain circumstances where pregnant women should be included in clinical trials or could be considered. That's relatively new, and what has happened in the past is. Women have enrolled in clinical trials and then became pregnant, not planning it, and so there've been so-called accidental pregnancies that have happened in clinical trials, but usually not enough to be able to say, something that's meaningful out of those pregnancies. So where we got started in this was actually a drug used for rheumatoid arthritis, leflunomide. Areva was the brand name, which was contraindicated from the day it was approved in pregnancy because it caused birth defects in animal models, and a couple of other things about the mechanism of action. But there were no human data to say that in fact it was harmful in pregnancy, and so we were able to set up the exact study design I described, where people contacted us through the services who found out they were pregnant, had the exposure, read the label and said, oh my gosh, this is a drug that's contraindicated and I've already taken it. Should I be worried? And we were able to follow those, close to 100 of those pregnancies and women who had rheumatoid arthritis who hadn't taken the drug and compare the two. And to date, that study and a couple of other ones that have been done have not identified that drug as causing harm, a human teratogen in human pregnancy, so sort of contradicting what the animal data had suggested would happen in humans.
interesting? Uh, okay, so let's talk a little bit about people with spondylitis or spondyloarthritis, depending on the day that we want to, which one we want to call
Right.
it. So when you've got something like spondyloarthritis, I think a lot of us take medications. What is what is unique about those challenges when you've got a chronic disease and you're moving toward pregnancy?
Yeah, it's some of the same challenges that everybody has. They come down with the flu, or have another kind of infection, or break a bone or something and need to take some kind of medication for it, and it's acute. And so they are, the clinician or the patient may say, gee, what can I take over this short period of time, this time in pregnancy? And it's more a looking forward sort of process about what would be the thing that I would feel the most comfortable taking. People with chronic diseases, like what you're describing, it's kind of a different story. I mean, you likely have had this before pregnancy. You likely have a chronic condition that needs treatment. And you also are in a position, I mean, this is true for a lot of chronic diseases, asthma being one, that undertreating or not treating the disease in pregnancy can be harmful to the pregnancy and to the baby. So it's kind of that balance. And I think what's important and unique to chronic conditions is that thinking, if you're planning on having children at all or may get pregnant, these questions are going to come up. So you have the opportunity to work with your provider in anticipation of maybe a pregnancy that it may not happen. You may not even be planning it for years, but to be thinking about what are the things that I would want to consider, what's the space I'd want to be in terms of control of my condition and being on medications that I feel comfortable taking in pregnancy before I ever get pregnant. So as we all know, 50% of pregnancies are unplanned in the United States. And so people do the things they would normally do and then find out they're pregnant. And even with planned pregnancies, you may not find out you're pregnant until several weeks in. And so you already then have had several weeks of development of the baby. So very best time to consider what medications you're taking, what control you're under in terms of your disease is prior to pregnancy.
Yeah, because it becomes a little bit chaotic and emotional, I think.
Yeah.
I recall my second child. I was visiting family and ended up with strep throat.
Oh.
And my mother sent me to my pediatrician in the town where I grew up. And I had a horrendous case of strep. And they said, "Are you pregnant?" And I said, "No."
No,
And
of course not.
like shots of antibiotics and was chugging all of it. And sure enough, I was
Yeah.
pregnant.
Yeah.
So it happens, but she's lovely and healthy.
Right.
17 years later. Okay, so we walked a little bit through the steps of how people get involved, and then what happens. Like, so if someone might reach out to you on a medication, what are the steps? How long do you follow people in those cohort studies?
Yeah, so it is a commitment in time, and so we try to be very upfront about saying that this is not a 10-minute conversation, and then we'll call you in a year and see what happened to you with your baby. We're collecting quite a bit of information. We're asking moms to commit to hanging with us for about a 2-year period of time, where we go through each one of the steps in chunks. It's not a huge amount of time, and we try to work around the mom's schedule. So if she's, it's easier for her to do an interview, very early in the morning or in the evening, we'll work around that. But what we ask the mom to do is to go through an interview, and they do it one-on-one with one of our specialists here, who will ask a lot of questions about pregnancy history and demographics and family history, and then specific information about what's happened so far in this pregnancy. How far along are you? Every medication, prescription or over the counter, recreational substances, caffeine, dietary supplements, vitamins and minerals that you might take, herbal products, each one of those, and in very much detail. When did you take it, for how many days, at what dose, and what was the indication. And so those interviews, that first one especially, can take can take a half hour or 45 minutes to get through. And that's sort of the biggest hurdle, but that's incredibly valuable data. And the mom is providing that to us before she knows what the outcome of the pregnancy is, and pretty close to the time all those things are happening. So it's the ideal time to capture it, not asking her a year later, can you remember, whether you took a Tylenol on the first Tuesday in November, which is pretty hard to ask people to remember. And then she will be scheduled sometime, if she enrolls in the first trimester, scheduled to do an update in the second and the third trimester. And then typically in those interviews, we catch up on whatever's happened since the previous interview, what medication she's continued, if she started any new ones, which she stopped. We do at each one of those interviews typically do a kind of assessment by mom's self-report of how her disease activity is. So how is she feeling at that point in time? And then when the pregnancy ends, whatever that the end of that pregnancy is, then we do an outcome interview. So that's if it was a live born baby, when was the baby born, how many days in the hospital, what type of delivery, size of the baby, and so on. And that covers the whole interview portion over that, maybe 9 or 10 months that she's been pregnant and after. And then the mom is asked to release medical records. And so we capture a lot of stuff that sometimes the mom doesn't know, about, when were the ultrasounds done and what were the, findings in those. So we ask her to release the OB record, her hospital of delivery record, the pediatrician's record. And then if she sees a specialist, a rheumatologist or whatever, for the specialist to release records related to the pregnancy. And then once we get those, we abstract information from those. And then we follow her child, if she has a live born baby, up to a minimum of a year. And during that year, it's really important because we know what the baby weighed and how long they were and what their head circumference was at birth. But we want to know, how does the baby grow over that first critical year? So what does their growth look like when they're about a year of age? And over that year, we're also capturing information on malformations or birth defects. And sometimes some of those just aren't seen when the baby's born. So it could be something, some kind of kidney anomaly that maybe was never picked up on prenatal diagnosis, child not having any problems, so nobody would know it was there. But maybe 6 months later, child starts having problems and they determine, there was a kidney abnormality that was present at birth. So that's one of the reasons we have that 1 year follow-up, is to make sure that we're capturing as much of that information as we can. And then we do typically two things. Try to get some assessment of development. So is the child kind of meeting milestones, interacting, motor and mental kinds of skills. And that's typically done by a maternal questionnaire, kind of a standard one that we do at 1 year of age. And then unique to most of our studies, and this is surprising to most people, is that we have incorporated into most of them a specialized physical exam of the child. And so this is no other study does this, but the reason for doing it is, let me say how it happens first, and then I'll tell you the reason for it. We have a group of pediatricians who are geneticists, or what are called dysmorphologists, so they're specialists in birth defects, who have fellowship training in this, so they're experts in it, and they really look at children from the standpoint of how their structure is put together, which may be subtle differences that aren't really a major birth defect. So a child doesn't have a cleft lip, but maybe the child has, an incurving of the fifth finger, or has webbing of the toes, or has an unusually wide distance between the eyes, or has ears that have a sort of a different configuration. So these things are not medically or cosmetically a problem for the child, or they would be major. They're not anything that causes a child any problem, But they could be a kind of a signal that something different was going on with that child when it was developing. And so that's why we do these specialized exams, because they could pick up something that was happening in maybe 10 or 15% of the kids who had the exposure that's not happening in the comparison group that didn't have the exposure. And if that happens, if you see something, some pattern of these little tiny differences in the exposed group, it's kind of a red flag that something's going on. We don't know what it is, but something's going on, but it deserves further follow up. So maybe we want to follow these children longer, beyond 1 year. Maybe we want to do ask the parents if they'll participate in longer term follow up. Um, Compare to other data sources, but it's just a special, extra special, careful look at these children to make sure we're not missing something that we could have picked up. And it's a perk, I think, for the parents, because they get to be seen by the specialist. We used to do these with house calls for 20 years. We've done them with house calls across the U.S. and Canada, which was always a treat for me to go along on those. Families, I think, loved it. But since the pandemic, we've been doing them by telemedicine, which is obviously more convenient for people to
Right.
be able to schedule. But I think it's a perk. It's great for the value of the study, but for the parents, because they get that kind of feedback. So at the end of the exam, that even though the examiner does it blinded, so they don't know whether the mom has spondylitis or not, or whether she took the medication or not. But they do give feedback to the parent. And sometimes, this doesn't happen often, but sometimes they come up with something that maybe their pediatrician missed. And they can help say, I think you should have this evaluated, or if you want, I'd be happy to talk to your pediatrician. So there have been a few instances where there's been some additional benefit for the families in being able to get that extra evaluation.
That's amazing. And I imagine as you're collecting information, in my head, I'm picturing you've got this huge spreadsheet of
Yeah,
every medication, and
yeah.
you just keep adding people to the cohort and then following and really enriching the data over time.
Absolutely. I think our we want to be a resource that's available for any research question that might come up. So, you know, uh, well, certainly during the pandemic, people were starting to take Paxlovid when they came down with COVID, and there were no human data about pregnancy. And so we had the opportunity to be able to sort of collect that information without there being any specific funding for it. We do have quite a few studies that are specifically funded by the manufacturers of those drugs, because the FDA tells them they have to. So a drug gets marketed, and that's the point in time where the FDA has the leverage to say, okay, as part of the approval, you need to study this drug in human pregnancy. And so that oftentimes they will come to us and say, okay, we've got this new drug. We need to study it in pregnancy. And then we fold in trying to locate people who have had exposure to that drug and comparison moms, and do that study within our overall pregnancy cohort. So it's kind of an ideal situation that you don't have to reinvent the wheel for every one of these studies. We have a kind of a platform already in place.
Yeah, that's cool. And I imagine, I mean, I lay awake at night and think about these things, but from like a data perspective, the richness, if there was a standardized way to look at this, because
100%, 100%. I'll give you an example is that all of the data are, collected to the same standard for whatever the exposure is, and the same breadth of data that's collected. And then something comes up, and one that came up recently was, gee, there was all of this interest in hydroxychloroquine potentially being a treatment for COVID, which it turned out it wasn't effective. But then people started to say, gosh, we don't have a whole lot of safety data on hydroxychloroquine in pregnancy. So we had collected it, and it wasn't any particular sponsored study, but we had collected it. So we were able to pull data, collect it to that same level of quality,
yeah,
and to be able to put together an analysis and publish a study that really, I think, helped to provide reassurance to people who take that medication in pregnancy.
That's so interesting. Okay, so can we talk about AS medications and if you guys have done any work there?
Well, so I'll say we completed the pregnancy registry for Enbrel and for Humira, and both of which might be used for AS, and both of which the findings were reassuring in general about the outcomes of pregnancy, and ended up in the label. The product label. So I think, contributed there. We have done the pregnancy registry for Zolgans, one of the uh, JAK inhibitor. And although infrequently used in pregnancy, at least in our experience, so we had very few exposed pregnancies, so wasn't a whole lot we could say at the end of the day. And then we're just starting one for Bimzelx.
Oh, interesting.
Yeah. And then of course, it's the whole range of pain relievers you might take, like nonsteroidal anti-inflammatory drugs and so on, that those get captured, as part of the data that we collect, because we collect every exposure. And I think really importantly, we collect over-the-counter medications too, and most data sources that you look at, like medical records or claims data, will not have over-the-counter medications because they don't generate a claim or end up on the record. So we can capture data on over-the-counter purchased nonsteroidal anti-inflammatory drugs and so on.
Oh, interesting, because it's not being tracked in the electronic health record.
Right.
Interesting.
Yeah.
You haven't been to my rheumatologist. If you're eating a cookie, they want to put it in your record.
Put it in the record. Right.
They totally want to know. Maybe for that reason. And so, okay, so when people, I suppose our listeners could, if they have these concerns, they could reach out.
Yeah.
Do you, once the baby has been born,
Mhm.
like if you had a 2-year-old and you found out about this, would you still recommend people give you a call if they've been on something that maybe wasn't
Yeah.
researched?
Yeah, so that's a really interesting question, and of course, more information is better than less information. But I will say that uh, the way we've structured these studies is to do what's called prospective ascertainment. And by that, I mean that, like I was mentioning, that people call us and give us all this information about their exposures and so on before they know the outcome of pregnancy. So it's thought to reduce some of the biases, that could lead to mistaken interpretations. Because if you ask somebody, after they've already had a child with a birth defect, or they've had a baby born preterm, maybe they remember differently than a mother who's had a normal outcome of pregnancy. It's hard to know, but it's possible, because having that knowledge might color how you think back. So that's why we structure these where the main focus of the study is looking at people who enroll with us before they know what the outcome is. So those kind of prospective enrollments are considered the most valuable. It's the closest we get to a clinical trial, to mimicking a clinical trial. But we typically do capture data on people who come to us who say, I had a miscarriage and I had exposure to this drug. I had I had a normal pregnancy, but they don't tell us until after the pregnancy is over. So they're looked at sort of separately, because they don't have that same kind of pure, I don't know the outcome yet. People
Right.
have come to us where they already do know the outcome, or they took the drug for an off-label indication. So maybe it's approved for AS and they took it for something else, or there could be a number of reasons why they don't fit this prospective cohort. So we try to capture that information anyway. And the reason is, if there was something in the prospective cohort, if we saw, I don't know, 3 children had, some cluster of birth defects that are as unusual, and we just wouldn't expect to see that, happen by chance. Could we look at this, what we call retrospective exposure series, and say, well, there's another case here. So we just don't want to miss something that might be informative, but they're kind of treated separately. So that being said, um, usually this is happening in the context of us enrolling in the study, and somebody would contact us and enroll pretty shortly after pregnancy and not 2 years later. So we haven't typically enrolled people who would come to us 3 or 5 years later. We do have people come to us who've enrolled with us in the prospective cohort, and the study ends, at a year, and they may come back to us at 4 years and say, my child's been diagnosed with autism. It's not one of the study outcomes, but we do capture that information if they want to give us additional information.
Yeah, well, sure. And I think there's this idea of when you're doing studies like this, and I'm not a like a clinical researcher by any stretch of the imagination, but what I have seen in some of the data sets that we tend to overlook is like, we're like, that's an outlier. Let's toss that
Yeah.
out.
Yeah.
But when you have an outlier that then becomes 4% of the population or something, you're like, oh. And I think there's a lot of that goes on in the learnings. And yeah,
Absolutely. Yeah, our goal here is to try to tease apart what's going to happen anyway. You know,
right.
that you're going to have 4 or 5% of pregnancies that'll end with a birth defect, no matter what. You're going to have, 8 or 9% that ended preterm delivery, no matter what. So what we're looking for is there an increase over the baseline, which risk everybody has for any one of those adverse outcomes in people who have the exposure, in a way that we can attribute to the exposure to the drug and not to the underlying disease. So I think that's just what you said. That's what makes that important, because it's so easy to say, and I'm sure you can appreciate this, to say, you read about, somebody who had a bad outcome of pregnancy and she took this drug, and the immediate reaction is to say, well, the drug must have caused it. And you can't know.
Right.
So it requires these types of studies to be able to say that was part of the baseline, normal risk that everybody has, and not attributable to the drug. But if you can look at it in a sufficiently large enough sample to be able to say that.
Yeah, and I think there's also this, and I don't know how familiar you are with spondylitis and our umbrella of diseases, but there is also a lot of, not necessarily on the birth defect side, but we do see a lot of like, this is not connected to this.
Mm.
And we're complaining for 10 or 20 years, and then enough builds up. And
And they say, guess what? It is
that's
connected.
right. Yeah. Yeah, exactly. I've heard a lot of things over the years. Okay, so we're going to go on to the word I can't pronounce, and the research you're doing around, is it teratogens? Did I get it?
Strategy. Yeah, you got it.
All right. Uh, Tell me more.
So the goal here is that we know there are a few drugs that are cause birth defects, and ones that people are most familiar with are thalidomide, that many years ago, and still is a drug on the market now in the U.S. That people who took this in the drug, or take this drug in the very early weeks of pregnancy, have a pretty high risk, maybe 20% or so, of having a baby with severe limb birth defects, arms and legs. And that was kind of the first one that we recognized where a medication could actually cause birth defects. And then another one that people are probably familiar with is isotretinoin, or originally marketed under Accutane, as a
Oh, yeah.
cystic acne. That drug it's a vitamin A derivative, and it is associated with a pretty high risk of having a baby with ear anomalies, heart and brain abnormalities. So it's a very potent human teratogen, and that's why you go through for both of those drugs, that's why you go through a whole pregnancy prevention program when you get prescribed them, because we know how harmful they can be in pregnancy.
Interesting. Can
Yeah.
I pause you on that one? Is it tretinoin? Is that the drug?
Yeah. Yeah, so there's isotretinoin is the drug. So
Okay.
some people kind of lump it in with retinoic acid, the topical drug, which doesn't seem to have the same ability, which you might appreciate when you're talking about something that's not taken orally, but would have to be absorbed through the skin to get into the bloodstream and so on. So the dose is quite different. Yeah,
Okay.
yeah,
It,
and then there are several seizure medications like valproic acid that increases the risk of birth defects, but probably the vast majority of drugs do not. So the goal here is we want to identify those that do by doing this type of research as early as possible, so that people can have a choice, so that they know, like with thalidomide and isotretinoin, don't get pregnant on this drug. So if you have the potential to get pregnant, avoid it while you're taking this drug. And then for the vast majority of other drugs, we want to be able to say, gee, there's no indication that this is a teratogen, and that reassurance is humongous. If you've got drugs that you would benefit from by taking and continuing to take during pregnancy to have a better outcome for you as a mom, and hopefully for the pregnancy, then having that reassuring data is critical. And that otherwise, I think moms will continue to be undertreated or poorly treated in pregnancy.
yeah, I mean, right, we panic
Yeah,
once you
of course. Of course,
something,
that's human nature. And you
uh, and
and
most of us,
mothers
right,
want to
well,
protect the baby. Yeah,
yeah,
so why not?
right? Okay, so you guys have been doing this 25 to 30 years. Do you have any idea on overall impact of the research and how it's shaped vaccine or medication recommendations?
Yeah, I think a number of the studies that we have done have ended up in the product label, which is one way of getting information to clinicians about what's known about the safety of a drug. So I think that's important in terms of impacting clinical practice. We also do publications in the scientific literature, so that's important in terms of maybe a broader audience understanding. Uh, and these publications have led to professional societies like the American College of Rheumatology. Periodically does a reproductive health guidance, and some of those publications have led to helping to frame what that reproductive health guidance is for some of the medications that are used. So I think they have helped change clinical practice. I think the biggest issue is it just takes too darn long. And the typical time that it takes to complete a pregnancy registry is close to 10 years. And that's just too darn long. So it's sometimes it's because the drug's infrequently used, but oftentimes it's just because we have a pretty clunky system for getting people into pregnancy registries. So sometimes the mom doesn't know one exists. Sometimes the clinician doesn't know. Sometimes they think, well, I have to go find which phone number to call, and I'm not sure if this person is qualified. So the system we've had has not been very conducive to, if there are pregnancy exposures occurring, streamlining the way that we get them into a pregnancy registry so we can get to these answers more quickly. There's no reason why this should take 10 years. So I've been working over the last couple of years is to try to promote the idea that we should be doing this as one single pregnancy registry. We should not
Yes.
have a different one for every drug and a different one for every disease. We should just say, here's it. You go here. You're on a new drug. You go here. Don't have to think twice about it, and sort of standardize the whole process. And I think we could speed it up and do it a lot less expensively that way.
Yeah, I agree. I met in the not too distant past the doctor that started the National Cancer Registry
Yeah,
and
yeah.
had that moving. And but I agree. And there, it seems to me that if we one, I would think, is that related at all to like policy or regulations?
I think it is. I think ultimately that if the policy and the regulators, I mean, the regulators want us to get the data. They, whatever way that we can get good quality data, they want to have it happen.
Right.
Industry, wants to fulfill their commitment. So this, I think, seems to be sort of a meeting of the minds, that it meets both sides' needs or purposes. It's cheaper for industry, faster for regulators, and most importantly, it helps the patients, because if they don't have to wait an extra 5 years to find out the answer to their question. That's a lot of anxiety.
Yeah, and I wonder, I just think of like how electronic health records work, and if you could put something in there where it's just funneling you all the information.
You just read my mind. I think that is a no brainer, and
Yeah,
there's just a few dominating the landscape, EHR
right.
systems. It's simple enough to have a alert that this drug, new, mom pregnant, this is where it goes.
Yeah, and that's an easy one. I think the EHRs are difficult in the sense of uh, there's a lot of uh, noise, or not noise, but like inconsistency in the data sets.
Yeah.
Um,
Well,
but maybe,
it's one
maybe,
of the reasons why we collect data directly from the mom, because she's the only one who knows whether she took the drug or not and when she took it.
yeah, that's interesting. How many women in the US are born, have children born with birth defects
You know,
annually?
it's about 4 or 5%, depending on what resource you use. And how you count birth defects. So some people will count ones like a heart defect that resolves spontaneously, won't count that, and some do. So you see estimates that are as low as maybe 2%, and some that are a little higher. If you follow the children longer, they'll be longer. I mean, the number will be higher. So it's not insignificant. If you think about it, it's about one in what 30 or so
Yeah,
babies. Yeah, and some of them we know what causes it. The mom has poorly controlled diabetes. Some of them are genetic, and we know what the genetic underpinnings are. But the majority we don't know. And that's a big, not only a big issue for the talking about the mom. If she has a child with a birth defect, she may look back and say, what is it I did? What could I have done differently that would have prevented this? And that, kind of overwhelming thing that she or the dad might bear, is awful. If we can dispel that and say that didn't have anything to do with the medication you took. And then there's the recurrence risk. So what's your expectation in terms of, would this happen again?
do you have any sense of, if you could have every woman in a pregnancy registry,
Mhm.
do you have any hunch on like how you can bring that number down?
100%. I honestly think that prevention is knowledge in terms of pregnancy planning. And so if you take methotrexate, we know that you should go off it before you
Yeah,
get pregnant. So if we knew which drugs you needed to avoid, and if you're a woman of reproductive age and have even a small chance of becoming pregnant, then maybe you take another drug, take one that we feel more confident. That if we did this, we would know that sooner, and we could do a much better job of managing those risks through prevention. And then, certainly during pregnancy, maybe a drug carries, a low risk of something. When you talk to moms, they oftentimes think, and I think you'll appreciate this, if you say there's a risk for, a birth defect with this drug, they think it's 100%. That's just knee-jerk reaction, as you think, if it causes a birth defect, then I have 100% chance of that happening, which is never the case. And so
right.
if there's a risk that you're willing to accept, it's raises the risk from 1 in 1,000 to having a baby with spina bifida to 2 in 1,000. Are you willing to accept that? And that, or it's something that's repairable, or that you would be able to deal with. That having that knowledge is really critical in being able to say, we can deal with this, and in ways that we can prevent it, we can prevent it.
Yeah, that's huge. Uh, okay, research for spa. You mentioned there is some study going on
Mhm,
with one of the biologics.
mhm.
If people want to get involved, how do they reach out to you, or if they want to get involved in your mission?
That well, both ways. So they can contact us through the website mothertobaby.org, which has telephone number, how to contact us by email. We have a whole team here who can respond to questions that anybody might have, and we would love to hear from people that are part of your group who not only have questions about themselves, but also, like you said, might have ideas about how to spread the word. We would love to be able to talk to more patients. In fact, we're just planning for a FDA sponsored pregnancy registry workshop. And we'll be reaching out and asking some people who participated with us before if they would represent the patient perspective of what it's like to not know what it's like to take part in a pregnancy registry. So we welcome any comments, suggestions.
I love it. That's amazing. Did I miss anything? This has been really interesting.
I think we got it all. One thing I will say, and this is a little bit bridge too far, but and I'd be interested in what you think about this. That so often we focus in pregnancy registries and pregnancy studies in general are focused on the immediate outcome. So does the baby have all their fingers and toes? Were they born full term and so on? But I think we think that moms care equally about how will my child do in the first grade in school, and and that is almost never studied in these studies. It's the rare situation, and it's usually not mandated by the regulatory agencies to do that. That it isn't kind of part of what the requirement is, and yet it's not that difficult to do. So we have a couple of studies where we've continued to follow the children up to 5 years of age, and the moms are willing to do it. They fill out questionnaires when the children are toddlers, and then they get to be just about school age. And we do face-to-face testing. So we go out and this is like before they're going into kindergarten, so they get feedback on how's my child doing in terms of their cognitive abilities, and so on, language development. And we also test the moms because the biggest predictor of how your child will do is how you do yourself.
Oh, interesting.
Yeah, and that's it's a nice perk for the parents, but it's incredibly valuable information for clinicians and parents to say, "Gee, we don't think there's anything here with the birth outcomes, but we really feel good about the fact that we really don't see anything in terms of how these kids are doing when they get to school age."
Yeah, I mean, to me as a parent and as somebody who has had to take some of these medications, and my children may too,
Yeah,
uh, I think that's very valuable. And it's also as a parent, there's this as you move through the years,
yeah,
there's this, what is normal,
yeah.
what is not. And I think, one of them I always think of is like ADHD.
Mm-hmm.
And is that on the severity scale? Is that related to things we're doing in pregnancy? Is it related to just the way we're wired?
Mm-hmm.
Uh, I think sometimes it's some of us just don't belong inside a system that
Right.
that doesn't appreciate creativity.
Right.
But there are things there, and I've talked to friends and over the years that, to your point, have asked themselves that question, like, "Is this my fault?"
Yeah. Well, and it's just the critical reason why you have to have a comparison group. So
Yeah.
maybe ADHD, occurs in, I don't know, 10% of kids born to moms who have AS, and 10% of kids born to moms who take this drug for AS, and that's it. And that's hugely reassuring that this would have happened anyway,
Yeah,
whether you took
interesting.
the drug or not. Yeah. But if you're just the N of one, you don't know.
Yeah. That's and that's what I think, like, an SAA, to land that, like, that's one of the things where I have found, even just doing the podcast now for a couple years, is the community that it creates, and people
Yeah.
start to have more understanding of what everyone else is going through whether it's emotional or in the evidence-based sides. Not that
Absolutely.
emotions aren't evidence-based, but yeah, this is exciting. I love it. And is Mother to Baby the largest group in the
I
US and
think
Canada?
so. Yeah, there are a number of like contract research organizations that do pregnancy registries, but most of them we think we do the best job because we have a comparison group instead of a single exposed arm, which is kind of hard to interpret, and having
Yeah.
that specialized physical exam. So there are other groups that do them, and there's a couple of academic ones. There's a really great collaboration for the HIV medications, that so all of those antiretroviral uh,
Mhm.
drugs go into one kind of omnibus pregnancy registry, with all of the companies that make them. And then there's an academic one for the anti-epileptic drugs and one for psychiatric medications. So I think I want to make a statement though about your community of people. You know, so often you might say, well, just my child have ADHD because they just would have had it anyway. And then you talk to your friends in the community and somebody else says, well, my child has that, or my child, and maybe it's not ADHD, maybe it's something, not.
Psoriasis,
Yeah, or they have
uh,
some ophthalmologic problem that
right.
you think, well, why? That's weird. Two other people said that. That is such a huge source of important information. And it can feed back into a study to say, have you looked at this? Is it possible to know whether or not this is occurring? Do you see that in your data? And we've had those questions come to us. Have you seen that? Yeah, have you seen this occur?
Yeah.
So I think it's a really important, not to be discounted source of
Yeah.
new
Well,
questions.
and I'm gonna ask you one final question on, at the tail end here. Given some current events, like, what is the impact of some of, like, the loss of funding or that's coming from the new administration? What
Yeah.
is that gonna do, and who does that impact from your perspective, like, from your work?
Well, we don't know, how it's going to play out yet. I mean, obviously, a lot of people are nervous about it. Um, I, I mean, I hope that we've made a case for how critically important this is for the health, of children in the nation. And if the administration stands by what they say they want to do is make, America healthy and have a focus on children, then I think the work that we do is exactly supporting that. I think people are, um, uh, trying to get their feet on the ground now to figure out what's going on. And of course, we are as well looking at. We have NIH funding, we have industry funding, and foundation funding, and so on. What are going to be the ways that we can continue to do that to meet our obligation to the public, and continue to do that as the landscape changes in terms of resources? And I hope I mean that may be an uphill battle, but we're in it for the long haul.
Well, I like to think we're gonna invest in our children.
I hope so. Who else should
Right?
we invest in? Right.
All
Yes.
right. So on that note, we are going to wrap it up. Thank you so very much for your time. This has been great. And yeah, we'd love to have you back especially if after you finish the newest research.
Okay. Thanks, Jill.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.